Hello, this is Kim Jong-il. Today's topic is part 4 of orthodontic differential diagnosis, which is about extraction treatment. As discussed in previous lectures, aesthetics is the primary aspect to consider in orthodontic diagnosis. If the patient has poor aesthetics, extraction treatment is likely to be carried out. The next criterion to consider is the combination factor. If CF is small, indicating high angle, there is an increased possibility of extraction treatment. Even if aesthetics is acceptable and CF is large, teeth have to be extracted when non-extraction approach is difficult. And the amount of lower anterior crowding is important in this aspect. Here are the criteria for extraction treatment. 1. Aesthetics protrusive lips can be treated only with extraction treatment, and POP should be taken into consideration. 2. High angle patients have low CF and usually steep POP. 3. Lower anterior crowding, whether the arch is constricted or not, should be considered. First, the amount of lip protrusion is evaluated for aesthetics. Protrusive lips are closely related to the positions of incisors, which are assessed with yawn to FH, loan to MP, IMPI, and interincisal angle. The degree of lip protrusion can vary depending on the inclinations of the incisors. There are a number of studies about changes in lips in accordance with upper incisor retraction. 1 mm of retraction of the upper incisors result in a change of 2.5 degrees of inclination. So a change of 7.5 degrees of linguversion means a 3 mm retraction of the upper incisors. And this 3 mm of retraction results in 1 mm of upper lip retraction and 2 mm of lower lip retraction. Then how do lips change when the lower incisors are retracted? There have not been any significant results yet. I categorize bialveolar protrusion into low angle with round face and high angle with long face. Patients with round faces would have normal POP, and those with long faces would have steep POP. Patients with low angle type BP would have normal UOP and POP, and those with high angle type BP would have normal UOP but steep POP. In case of normal POP, the lower first premolars can be extracted in order to maintain POP while considering the Cannon key. On the other hand, in case of steep POP, I normally extract the lower second premolars in order to flatten POP. High angle type has low CF and steep POP, and steep POP is closely related to the characteristics of class 2 malocclusion. What happens in a premolar extraction treatment when the molar relationship is class 1 but steep POP is maintained? The upper incisors will be retracted by a large amount and at the same time extruded. There is more retraction of the incisors, but it can lead to unaesthetic profile. In contrast, when steep POP is flattened, the upper incisors will be retracted by a lesser amount, but will be intruded, leading to a more aesthetic profile. In an extraction treatment, both the APE and vertical controls are necessary. However, in MEIW orthodontics, the main purpose of extraction is vertical control rather than APE control. The problem in vertical control is low CF, high angle, which indicates the posterior discrepancy. In other words, extraction is considered when there is a posterior discrepancy. Third molar extraction should be considered first, followed by second molar, second premolar, and lastly first premolar. What are the possible problems in non-extraction treatment in high angle? When there is not enough posterior available space but the lower molars are uprighted because aesthetics is acceptable. Non-extraction treatment results in backward rotation of the mandible and labioversion of the lower incisors. And labioversion of the lower incisors lead to unaesthetic profile. Let's think about CF, malocclusion, and posterior available space. High angle and class 2 malocclusion are characterized by lack of PAS, which leads to an increase in premolar extraction. On the other hand, low angle with round face and class 3 malocclusion are characterized by sufficient PAS, which means that the treatment can be effectively carried out by extraction of the lower third molars rather than the premolars. Lower anterior crowding can be assessed by drawing a circle that connects the mandibular active centric line, including contact points between the second premolars and the first molars, cusp tips, and incisor edges. If the premolars are located inside this circle in constricted positions, the arch can be expanded for non-extraction treatment. However, if the premolars are on the circle in normal positions, and there is a lower anterior crowding, teeth have to be extracted. Therefore, when there is a lower anterior crowding, arch constriction should always be evaluated. The possibility of premolar extraction greatly increases when there is a lower anterior crowding, labioversion of the lower incisors, and protrusive lips in profile aesthetics. Treatment options can be categorized as follows: 1. I44 or 44 extraction. 2. I44 or 55 extraction. 3. I55 or 55 extraction. 4. Only I44 extraction. 5. Only I55 extraction. 6. Unusual premolar extraction. Asymmetric extraction. If class 1 molar K is the objective of treatment, both the upper and lower premolars have to be extracted. However, if the goal is to achieve class 1 canine K, only upper premolars can be extracted. In this case, the final result will be class 1 canine K and class 2 molar K. It is crucial to set class 1 canine K rather than molar K as a goal when devising a treatment plan. In orthodontic diagnosis, it is important to think about whether the lower incisors or the upper incisors are prioritized. Conventional orthodontics makes extraction decision based on the position of the lower incisors. The upper incisor position is normally evaluated by Yon to FH. 114 degrees is normal angulation, less than 100 degrees means linguversion, and greater than 120 degrees means labioversion. The lower incisor position is evaluated by Lone to MP, less than 85 degrees means linguversion, and greater than 95 degrees means labioversion. What are possible problems when the diagnosis is focused on the lower incisor position in conventional orthodontics? In a class 2 malocclusion, the lower incisors are labially inclined, and often IMPA is greater than 95 degrees. In order to adjust IMPA to 90 degrees, the lower premolars have to be extracted, and the upper incisors have to be retracted a lot. However, how does the diagnosis change if the upper incisor position is determined first in an aesthetic state? In order to achieve proper overbite and overjet, the lower incisors can be slightly proclined. For the same class 2 molar occlusion with large overjet, the treatment can be different depending on its focus. In a class 3 molar occlusion, often the lower incisors are lingually inclined. How is this treated if the focus is on the lower incisor position? In order to upright the lower incisors to 90 degrees, they have to be proclined, which can increase the likelihood of surgical treatment. On the other hand, orthodontic treatment, focused on the upper incisor position, will allow a slight labioversion of the upper incisors and adjustment of the lower incisors, thereby achieving proper overbite and overjet. In this way, non-surgical and non-extraction treatment becomes possible. Normally, the extraction of the upper and lower first premolars results in an extraction space of 7.5 mm each side. Since 1 mm retraction of the upper incisors results in 2.5 degrees of tipping, 7.5 mm retraction results in 18.75 degrees of linguversion. The normal value of yon to FH is 114 degrees. And if it is greater than 133 degrees, the posterior teeth should not be moved forward when the extraction space is closed. Even mini-screws might be needed in order to maximally retract the upper incisors. Then the normal value of IMPA is 90 degrees, and if it is greater than 109 degrees, the lower incisors should be maximally retracted. I doubt there are many cases that corresponds to both of these conditions. Here are the upper and lower incisors with normal interincisal angle. In an extraction treatment, linguversion of the incisors occur and interincisal angle increases. On the other hand, in a non-extraction treatment, labioversion of the incisors occur and interincisal angle decreases. If interincisal angle is greater than 120 degrees, or especially greater than 130 degrees, non-extraction treatment should be carried out if possible. IIA of 110 to 120 degrees will be a borderline case. However, if IIA is less than 110 degrees, premolar extraction is likely. In a borderline group, IIA can be adjusted to greater than 120 degrees with non-extraction treatment, but it is difficult to do so if IIA is less than 110 degrees. The sequence of orthodontic differential diagnosis for premolar extraction is 1. Which teeth to extract to? How can we treat? And 3. How can we close the space? Here is a basic guideline for extraction, which all of us are already familiar with. In order to move the incisors back more, the first premolars are extracted. To move them back less, extraction of the second premolars is better than that of the first premolars. Extraction of the second premolars is preferable for moving the molars forward more. And extraction of the first premolars is better to move the molars forward less. The extraction choice can be evaluated with yon to FH, lone to MP, and IIA measurements. Here is a patient with anterior crowding and lip protrusion as chief complaints. Yon to FH is 106 degrees, meaning the upper incisors are lingually inclined. And IMPA is a normal value of 94 degrees. IIA is 128 degrees. In order to treat lip protrusion, extraction treatment is likely. Many orthodontists choose to extract the first premolars in case of lip protrusion. However, This will lead to worse interincisal relationship with large interincisal angle in this patient. So the upper and lower second premolars are extracted in this patient. The extraction space of the second premolar can be closed by less retraction of the incisors and more protraction of the molars as planned. In order to retract the lips more, the first premolars can be extracted. But if the patient does not want much lip retraction, the second premolars can be extracted. This patient has a prominent chin, so the lips appear to be retruded. Is extraction of the first premolar or the second premolar better for this patient? If the first premolars are extracted, the lips are likely to be even more retruded. So it is better to extract the second premolars, align the anterior teeth, and protract the posterior teeth. Extraction can be determined in order to achieve Class 1 canine key. In case of Class 2 canine key, the upper first premolars and the lower second premolars can be extracted. In case of Class 3 canine key, the upper second premolars and the lower first premolars can be extracted. In Class 2, the upper incisors are the key because lingoversion of the upper incisors lead to unaesthetic profile. It is important to prevent excessive retraction of the upper incisors. How about in Class 3? In Class 3, lingoversion of the lower incisors should be minimized because they are often already lingually inclined in Class 3. Therefore, extraction of the lower first premolars requires caution in Class 3 malocclusion. It has to be kept in mind that after space closure there is a finishing stage to complete the treatment. And it is different for Class 2 and 3 malocclusions. In Class 2 malocclusion, the finishing force vector is posterior movement of the upper dentition and anterior movement of the lower dentition. The same mechanism applies when miniscrews are used. Therefore, posterior movement of the upper incisors during space closure and finishing can become problematic in Class 2 malocclusion. On the other hand, in Class 3 malocclusion, posterior movement of the lower incisors can become problematic. Treatment of Class 2 malocclusion inevitably requires the use of Class 2 elastics in finishing stage. And the type of elastics to be used can be easily determined by a PDI. What is the expected tooth movement in an extraction treatment? The upper incisors are extruded and lingually inclined as they are retracted during space closure. And the same movement occurs in finishing stage. Therefore, in order to prevent excessive movement of the upper incisors, extraction of the upper second premolar may be better than that of the first premolar. However, the extraction of the upper second premolar makes key correction difficult in Class 2 malocclusion. Usually the upper first premolars are extracted in order to retract the upper incisors in Class 2 malocclusion. Then how about in Class 3 malocclusion? The lower incisors are extruded and lingually inclined as they are retracted during space closure. And the same movement occurs in finishing stage. In order to prevent excessive movement of the lower incisors, extraction of the lower second premolar may be better than that of the first premolar. Indeed, the extraction of the lower second premolar makes key correction difficult in Class 3 malocclusion as well. But because it is crucial to avoid too much lingoversion of the lower incisors, I recommend extraction of the lower second premolars, rather than the first premolars when extraction is needed in the treatment of Class 3 malocclusion. Let's review today's lecture. 1. When aesthetics is poor. 2. when combination factor is low as in high angle case. And 3. When non-extraction treatment is difficult, and there is lower anterior crowding, the likelihood of premolar extraction treatment increases. The next lecture will discuss in depth about which premolar to extract. Thank you for watching.